If we look in the curriculum of the college, it gives quite a lot of detail about what they expect you to know about in respiratory physiology. I've put it down into these main subjects. We're going to look at the control of breathing, we're going to look at lung volumes, and then respiratory failure, gas transport, oxygen delivery, and then a little bit on pulmonary oximetry, a little bit on pulmonary circulation, and a little bit on mechanical ventilation. Let's look at the respiratory centers. These are centers within the medulla and the pons, which have particular functions to do with the respiratory muscles. And these respiratory centers, as they're called within this area, there's various groups of nerves, generate rhythmic inspiration and then rest phases, and can also generate expiration. Because, of course, in most breathing, it's really just the inspiratory muscles that are active, and expiration is mostly just a passive, a relaxation. Moving on to measurements. The first one I'm going to talk about is the measurement of peak flow, peak expiratory flow rate. Now, we use this in particular in conditions where there's airways resistance. Now, if you remember your equations about gas flow along pipes, it's very sensitive to changes in diameter. So changes in diameter of a pipe have a profound effect on flow rates. So variations in caliber of pipes, of tubes, have a big effect. And in asthma and other conditions where we have narrowing of the airways because of inflammation or muscle spasm or whatever, this increase in resistance, the narrowing of the bronchi, has a marked effect on airflow. And therefore, we can measure airflow as an indicator of the severity of disease and the effectiveness of treatment. Now, let's come to, I think, a very important set of variables, which are the static lung volumes. And this is the equipment that was traditionally used, a spirometer. So you've got your subject, your patient on the left, using a mouthpiece and some tube, and that tube enters the bottom of a container with water in it, and upside down inside that container of water is a bell-shaped container with air in it. And the pipe from the individual comes up inside that bell. It's a lightweight bell so that it moves very easily. And so as the patient breathes in and breathes out, that bell moves up and down within the water, and it's designed to move very freely. And attached to the bell, there's an arm and then a writing device and a drum that rotates, and the writing device writes on the drum. And that's the traditional method. And although we don't use that equipment anymore, it is so heavily influenced the way static lung volumes are drawn and understood and things. It's worth knowing that that's the origin of static lung volume measurements. That's where it all came from originally, that sort of technology.